chapter, that is developmental disturbances of oral and paraoral structures. First, the two basic definitions with similar sounds but different meaning, that is malformation and deformation. So malformation means there is error in morphogenesis. That means during the formation process something goes wrong that results in abnormal shape or structure. For example, cleft palate. During the formation of the palate, the two palatine shelves did not fuse with each other, hence there is a cleft seen in the palate. Whereas deformation means any alteration in shape or structure of a previously normally formed part. That means there is nothing wrong with the morphogenesis. The formation part was absolutely normal. Once the structure was completely formed, later on it got deformed. For example, plagiocephaly. The skull was absolutely normal once it was being formed. Later on, due to the pressure changes, it became flattened. That is flat head. Okay, so malformation versus deformation. Now let us discuss the anomalies of the teeth and their association with different physiological processes involved in tooth development. So the very first physiological process involved in tooth development is initiation and proliferation. Basically, initiation and proliferation mainly affects the number of teeth. Okay, so if there is no initiation at all, so there is complete absence of teeth, that is endodontia. More proliferation, then it will result in supernumerary teeth. Less proliferation, then it will result in lesser number of teeth, that is hypodontia or oligodontia. Hypodontia means the number of missing teeth are less than 6, whereas oligodontia, the number of missing teeth are more than 6. Recently, a new terminology has been introduced, and it was a question in your recent AIMS 2020 paper as well. Oligopleodontia. Now, what is oligopleodontia? This, as the name suggests, oligo means less, pleo means more, dontia means teeth. I'm sorry. So this term has been used for concomitant, hypo, as well as hyperdontia. That means less number of teeth plus presence of supernumerary teeth. Okay, this term oligopleodontia was introduced by the scientist named Nathaniel. Okay, whereas concomitant hypodontia has been introduced by the scientist named Gibson. Those scientist names are not commonly asked, but oligopleodontia means hyperdontia. Well, there was a case report for oligopleodontia. In this case, as you could see in the clinical picture, there is presence of this supernumerary teeth, conical ones. One is mesiodense, another is on the palatal aspect of the incisors. Supernumerary teeth, plus in this OPG one could make out the second premolar is missing, that is hypodontia. Okay, so this is, they might show such picture and ask what is the condition shown in the given pictures. There is presence of the supernumerary teeth as well as few teeth are missing. Even the third molars are missing, though they are not taken as normal, but second premolar is definitely missing. So this is a classical example showing oligopleodontia. Now this oligopleodontia can be seen in Down syndrome, cleft lip and palate, fucosidosis. Now this fucosidosis is one of the lysosomal storage diseases due to the deficiency of the enzyme fucosidase. Okay, there is accumulation of the sugars, so hence it is one of the lysosomal storage disease. Then is Dubowitz syndrome and Alice van Creveld syndrome. These are very rare syndromes. We do not need much details about them. Just that both these syndromes are associated with dwarfism. This is dwarfism. Dubowitz means in this the patient is mentally retarded, whereas in Alice van Creveld, though dwarfism is present, but the patient has normal intelligence. Okay, rest of the details are not required. Alice van Creveld syndrome, the patients have normal intelligence. Okay, both these syndromes, Dubowitz as well as Creveld syndrome, are associated with dwarfism. Now, moving on to the next physiological process, that is histodifferentiation. The two important anomalies here are regional odontodysplasia. Now, few researchers count regional odontodysplasia in morphodifferentiation as well as apposition. Okay. Now, our order of preference will be, we will count regional odontodysplasia first in histodifferentiation, second in apposition, and third in morphodifferentiation. There is always an overlap. So this will be our order of preference. And the second example in this category is formation of osteodentine seen in association with vitamin A deficiency. Okay. Then is morphodifferentiation. Basically, morpho means the shape. So this, anything if goes wrong during morphodifferentiation will affect the shape of the crown. So either a large sized or a small sized, okay, or dense invaginatus or dense evaginatus, Hutchinson's incisors, Mulberry molars, cusp of Carabelli, Talen's cusp, taurodontism, they all are associated with morphodifferentiation, right? The last, but again the most important, is apposition. This is something to deal with the structure of the tooth. So if anything goes wrong during the apposition part, will affect the structure of the calcified structures, that is enamel. It could be either amelogenesis imperfecta or enamel hyperplasia, and dentinal structural defects, namely dentinogenesis imperfecta and dentin dysplasia. Now let us discuss some more important anomalies. First is gemination and fusion. Well, in both these gemination and fusion, the crown is large sized, so we call it as macrodont. This is an example of macrodontia. Okay, if one tooth is involved, we call it as macrodont. If more than one teeth, we call it as macrodontia. And another term that is often used to describe them is double tooth, because the size is big enough, it appears as if the size is doubled. Now, what is the basic difference between gemination and fusion? Let us take them one by one. First is gemination. Gemination is basically an attempt of one tooth bud to divide into bifid crown. Okay, one tooth is dividing to form a bifid crown and one common root. If this attempt is complete, the split is complete, then there is result of one normal tooth and one supernumerary tooth. In such a case, we call this as twinning. That is, one tooth bud has resulted into two teeth. Okay, one tooth bud giving rise to two teeth, one normal tooth as well as one supernumerary tooth. When the split is complete, we will call it as twinning. When the split is not complete, we will call it as gemination. Whereas two different tooth buds coming together and fusing at the level of dentine is fusion, wherein the two tooth buds will form sorry, one large sized crown. Okay. So rather than forming two normal teeth, only one crown is formed. So one large size crown is seen in fusion. If this union takes place at the level of cementum, remember C for cementum, C for concrescence, then we will call this as concrescence. So this, in this case, union is taking place at the level of cementum. Okay, so crowns are clinically normal. Crowns are clinically normal. Okay, let us summarize these four anomalies again. In gemination, one tooth bud is splitting into bifid crown, so the total number of teeth remains the same, that is 32. In twinning, this split is complete, so the number increases by 1, it becomes 33. In fusion, two different tooth buds rather than forming two teeth forms one common tooth, so number decreases by 1, that is, it becomes 31. As well as in concrescence, the crowns are absolutely normal, so the total number of teeth remains the same, that is 32. Okay. Next is enamel hypoplasia. Well, enamel hypoplasia is mainly of two types. One is environmental. If the etiology is any of the environmental factors like deficiency of calcium, excess of fluoride, any birth injuries, or any trauma or caries in deciduous teeth leading to the hypoplasia of the permanent tooth, such tooth or such a type of hypoplasia is called as Turner's hypoplasia. Okay. Or if there is any viral infection in the child when the enamel is actually getting formed, that leads to again environmental enamel hypoplasia. These are the few examples. The other is the hereditary type. Now this is also called as amelogenesis imperfecta. Many genes are involved, namely the important ones are amyl-X gene that codes for amelogenin, right? Or enam gene that codes for the protein enamelin. Then there is matrix metalloproteinase type 20. This encodes for enamel lysin. Okay, one, two. So these are the four important genes, and the fourth one is DLX3 gene. Okay, just remember the names amylex, enam, MMP, or DLX. Three genes are involved in amelogenesis imperfecta. Now, whether it is environmental enamel hypoplasia or hereditary enamel hypoplasia, they both can be further subdivided into three categories depending upon which stage of enamel formation is affected. For example, the very first stage is the stage of organic matrix formation. So, the first type is hypoplastic type. In this hypoplastic type, there is defect in the formation of organic matrix. Second type is there is normal formation of organic matrix, but there is incomplete mineralization. That is hypomineralization, which is also known as hypocalcification type. Hypocalcification type. And the third is hypomaturation type. Hypomaturation type. See, the basic difference between mineralization and maturation is that whatever crystals are deposited during mineralization, now they will expand, they will increase in size. There is increase in the mineral content, but there is no increase in the number of crystals in maturation. Okay. Now, Wittkopf's classification of amelogenesis imperfecta was based on these three types. Wittkopf's classification, namely, was based on the three stages of enamel formation plus the incidence of these three different types. Based on the incidence, he classified type 1 as hypoplastic type, type 2. Now here there is a difference. Type 2 is based on the incidence, hypomaturation is more common than hypomineralization. So type 3 is hypo mineralization or hypocalcification. Okay, hypocalcification means one and the same thing. Whereas the type 4 is the one which is associated with taurodontism. Amelogenesis imperfecta associated with taurodontism. Now these are further subdivided into autosomal dominant, autosomal recessive, sex-linked dominant, sex-linked recessive. We don't need that detail. Just remember type 1, 2, 3, 4. One is hypoplastic, hypomaturation. Type 3 is hypomineralization, and type 4 is the one which is associated with Taurodontism. Okay. Now moving on to the next type of structural defect, that is dentinogenesis imperfecta. Again, previously it was thought that this is associated with osteogenesis imperfecta, but the recent studies have proved that there is no association with the disease osteogenesis imperfecta. Different genes are involved in both these diseases. Dentinogenesis imperfecta is basically due to the mutation in the gene dentine sialophosphoprotein gene, that is dentine sialophosphoprotein, which is located on chromosome number 4p 16.3. This number 4 is important. You may forget 16.3. So it is located on chromosome number 4. Now, mainly two types of dentinogenesis imperfecta according to the revised Shields classification. Two types, type 1 and type 2. Type 1 is the conventional type, which is also called as opalescent dentine type, where you get to see opalescent crowns, and type 2 is the one which is also called as brandywine type. Let us take them one by one. The first is type 1. Important points to be remembered from type 1 is there are bulbous crowns are seen. Bulbous crowns with cervical constriction, as shown in the picture. Cervical constriction, bulbous crown, giving rise to tulip-shaped crowns. Tulip-shaped crowns are seen in type 1. Why these crowns are bulbous? Why there is cervical constriction? Because of atypical dentine formation. Atypical dentine formation, which is obliterating the pulp chambers. So there is obliteration of pulp chambers. Whereas on the contrary, in the type 2, which is also called as Brandywine type, there is no formation of dentine that leads to abnormally large sized pulp chambers. As shown in the picture, large sized pulp chambers, thin enamel, very thin dentine. This gives radiographically shell teeth. Where do you get to see shell teeth? Type 2 dentinogenesis imperfecta. Now, whether it is type 1 or type 2, what is common to both the types is the normal scalloping of DEJ is lost. The DEJ, dentino-enamel junction, appears to be flattened. Okay, DEJ becomes flat in both the types. Okay, the gene involved in both the types is dentine sialophosphoprotein gene. The next structural defect affecting the dentine is dentine dysplasia, again divided into two types. Type 1 is the radicular type. As the name suggests, it affects the roots. Okay, so roots are not formed completely. So what we get to see here is extremely short roots, as shown in this picture. Extremely short roots are seen in dentine dysplasia type 1. Okay. Now, what is happening in dentine dysplasia type 1? Again, there is obliteration of the pulp chambers with osteodentine. That is again a type of atypical dentine. So, there is a formation of osteodentine. Now, this osteodentine appears histologically as if it is being formed in cascades. That is called as cascades of dentine, or histologically gives us the appearance of lava flowing around the boulders. Lava flowing around boulders or cascades of dentine is seen in dentine dysplasia type 1. And sometimes few pulpal remnants are left behind that appear semilunar shaped, so we call them as crescent shaped pulpal remnants. All these are important questions from type 1. Crescent shaped pulpal remnants, right? Lava flowing around the boulders, cascades of dentine, or extremely short roots are seen in radicular type of dentine dysplasia. This is a picture showing lava flowing around the boulders or cascades of dentine, as if normal dentine is making an attempt to be formed, but it gets blocked, so it forms another layer. Then it gets blocked, it forms another layer. So lava flowing around the boulders is typically seen in dentin dysplasia type 1. And what is type 2? Type 2 is the one which is also called as coronal type. As the name suggests, it affects the crown. Now, in this case, rather than abnormal dentin formation, the dentin formation stops. So, this is again leading to abnormally large sized pulp chambers. This is the second condition we are discussing today, which results in large sized pulp chambers. In Dentinogenesis imperfecta, we have called large sized pulp chambers as shell teeth, whereas in this case, we are comparing them with a thistle tube. So we call them as thistle tube appearance of pulp chambers, or thistle tube shaped pulp chambers are seen in dentin dysplasia type 2. Okay. Then another defect resulting in large size pulp chamber is ghost teeth. This is also characterized by very large sized pulp chambers plus very thin enamel and thin dentine. Thus, if you take a radiograph of such a tooth, you get to see only a shadow, hence the name ghost teeth. Now, these ghost teeth is another name for regional odontodysplasia. This is also known as odontogenesis imperfecta. Odontogenesis imperfecta. One more common name is odontogenic dysplasia. Odontogenic dysplasia. One is dentin dysplasia, this is odontogenic dysplasia. One is odontogenesis, one is dentinogenesis imperfecta, this is odontogenesis imperfecta. Okay. Now, many times questions have been asked from the histopathology of the ghost teeth. That is very important. Histopathologically, what do we get to see in ghost teeth is wide predentine zone, wide predentine zone, and large areas of interglobular dentine. Both this predentine as well as interglobular dentine, they imply non-mineralized dentine, unmineralized dentine. Predentine as well as interglobular dentine are the one which are less mineralized, and there is presence of enameloid conglomerates. Now, what are these enameloid conglomerates? These are the calcifications seen in reduced enamel epithelium of unerupted teeth. We know that unerupted teeth are covered with reduced enamel epithelium. So the calcifications seen in reduced enamel epithelium are called as enameloid conglomerates. Okay. Moving on to the developmental non-odontogenic cyst, also called as fissural cyst. The very first is median anterior maxillary cyst. Rather, this is the most common developmental non-odontogenic cyst. As the name suggests, it is seen in anterior maxilla between the two central incisors. Most commonly, it exhibits heart-shaped radiolucency. See, the shape is not always present. Okay, it is not that always it will be heart-shaped radiolucent lesion. Shape can vary, but what will remain the same is their location. It will be always and always present between the two central incisors. Then only we will call it as median anterior maxillary cyst. Okay, the soft tissue counterpart of this median anterior maxillary cyst is called as incisive papillary cyst, or the cyst of incisive papilla. That is seen as a swelling in the incisive papilla. So it is called as incisive papillary cyst. This is the soft tissue counterpart of median anterior maxillary cyst. So it will show no radiographic finding. There will be no radiographic finding since it is present entirely in the soft tissue. Next, developmental non-odontogenic cyst is globulomaxillary cyst. As the name suggests, this is present in between the globular process plus lateral nasal process plus the maxillary process. Okay, where these three processes are uniting, there is entrapment of the epithelium, leading to the formation of this cyst, which is called as globulomaxillary cyst. Now, what is globular process? Basically, globular process, as you could see in this picture, is nothing. This is globular process, which is formed by the union of two medial nasal processes on either side. Okay, so this is basically the fusion of the medial nasal process from either side fuses together to form globular process. We know that this is also called as intermaxillary segment. The structures formed from intermaxillary segments are the philtrum part of the upper lip, the alveolus that bears the foresocket of incisors, as well as the interior one third of the palate. Remember, this globular process will give rise to the philtrum part of the upper lip, the alveolus, as well as the interior one third of the palate, which is also called as primary palate. Now, since the primary palate is the interior one third part, we are saying that this has come from the globular process, or this is also called as premaxilla, whereas the posterior two third has come from the maxillary processes. The palatine shelves, they have been derived from the maxillary processes. So this cyst which is formed between these location is here, where the primary palate is fusing with the secondary palate. So this is also called as premaxilla maxillary cyst, which is seen between the maxillary lateral incisor and canine. Okay. Most commonly, it exhibits inverted pear-shaped radiolucency. Again, the shape is not important, location is important. Inverted pear-shaped radiolucency. Now, according to the recent research, the concept of globulomaxillary cyst is obsolete. They say that such a type of cyst does not exist. They found out all the cases which have been reported in the past as globulomaxillary cysts and reviewed them. The review showed that some of those cases were either dentigerous cysts, some of them were AOTs, some of them were unicystic ameloblastoma, some of them were even OKC. Okay, but still, if a question comes from the previous question bank, then you have to answer it accordingly. But according to the recent concept, globulomaxillary cyst does not exist. The soft tissue counterpart of the globulomaxillary cyst is called as nasolabial cyst or Clesdet cyst that does exist. So this is considered as the soft tissue counterpart of globulomaxillary cyst. Since it's a soft tissue, as the name suggests, it is present in the soft tissue, so it leads to the obliteration of the nasolabial furrow. Okay, or obliteration of the vestibule, as shown in this picture. This is the cyst present here. There is obliteration of the vestibule or obliteration of the nasolabial furrow, and again, since it's a soft tissue cyst, so no radiographic finding will be seen in this. This is thought to get its epithelium from the remnants of nasolacrimal duct. Nasolacrimal duct. Okay. Next is questions based on special appearances. The first special appearance is cobblestone appearance. This cobblestone appearance is seen in Hicks disease, also called as focal epithelial hyperplasia. Now, this disease is characterized by multiple squamous papillomas or papules or nodules. They can either form multiple nodules that gives the cobblestone appearance, and which human papilloma virus is involved, type 13 and type 32. Okay, this is to be remembered. And other diseases which can show cobblestone appearance is pyostomatitis vegetans and Darius disease. Darius disease we will discuss again in skin pathology. What is pyostomatitis vegetans? Basically, this is an inflammatory stomatitis inflammatory stomatitis associated with inflammatory bowel disease. Okay, inflammatory bowel disease. Namely, what are the two important one in this category are Crohn's disease or ulcerative colitis. So in simpler terms, I can say that Piostomatitis vegetans is oral manifestation of Crohn's disease or ulcerative colitis. Another one appearance which is seen in Piostomatitis vegetans is cobblestone appearance. Another important appearance of the tongue which is seen in this is cerebriform tongue appearance, wherein large size nodules develop. So these nodules have been compared with the sulci and gyri seen in the cerebrum. So this is called as cerebriform tongue, seen in Piostomatitis vegetans. More commonly, they are seen in pemphigus vegetans. This will be our first preference. Piostomatitis vegetans is second preference, and the third condition where we can see such a type of appearance of the tongue is scrotal tongue. Okay. Now, what is scrotal tongue? Scrotal tongue is also called as fisher tongue or plicated tongue. Again, a developmental anomaly of the tongue. Etiology: what is causing such a type of appearance? Mostly it is seen in persons suffering from stress. Okay. Or hereditary also plays an important role, though the exact gene have not been located. What we need to remember from Fisher tongue is an important syndrome associated with this, that is Merkelson-Rosenthal syndrome. Okay, this is an important triad of facial paralysis, cheilitis granulomatosa. This is cheilitis granulomatosa, also called as Mishra cheilitis, and Fisher tongue. Okay, important syndrome associated with Fisher tongue. Next is elephantiasis gingivae. This is another name for hereditary fibromatosis gingivae, hereditary condition wherein the gingivas are enlarged to such an extent that they cover the entire crown. This condition is they lead to a type of edentulism which is not true. So this is called as pseudo edentulism. Okay, when these gingival overgrowths cover the entire crown, it appears as if the patient has got no teeth in the oral cavity. This condition is called as pseudo edentulism. Okay. Next is paglateral, wherein the incisal third is constricted. It appears in the shape of peg. This is seen in microdontia or congenital syphilis, wherein we call them as Hutchinson's incisors. Hutchinson's incisors. Okay. Next is, where do we get to see talon's cusp? Talon means extra claw. So this could be seen either on the labial surface or on the lingual surface of incisors. Which incisors? Lateral incisor is more commonly involved than central incisor. Okay. Talon means extra claw. So talon cusp means extra cusp. Now, depending upon the extent of this cusp, we measure the distance from cemento-enamel junction. We classify talon cusp into three types. Type 1 is the true talon, wherein the cusp extends from the CEJ to more than half of the distance. Okay, there is distance from the CEJ till the incisal surface. If this is also called as major type of talon, that is, it covers more than half of the distance from the CEJ till the incisal surface. Second is the minor type, which is called as semi-talon or type 2, where it covers less than, more than 1/4 distance, but less than half of the distance. Okay. And third type is the trace talon, which is called as type 3. It is nothing but a prominent cingulum when the distance covered is less than 1/4 of the distance from CEJ towards the incisal surface, that is the crown height. Okay. True talon type 1, semi-talon type 2, and type 3 is trace talon. Important syndromes associated with talon's cusp are Robinson-Tibby syndrome, important features in this is associated with the presence of broad thumb, okay, broad thumb, as well as broad first toe plus short stature. Okay, these are the important features here. Then Sturge-Weber syndrome, and this we will be doing in benign and malignant tumors. And Moore syndrome. Moore syndrome is nothing but a type of orofacial digital syndrome type 2. Okay. Now, what is this orofacial digital syndrome? Orofacial digital syndrome. This is characterized by, what are the oral features in orofacial digital syndrome? Either a cleft tongue or a multi-lobed tongue. Many lobes are seen. Median cleft lip. This is important. Median cleft of the lip, that is median cleft lip is seen. And polydactyly, multiple fingers. Dactyly word is for many fingers as shown in the picture. So this is orofacial digital syndrome. Okay, these are the important points from orofacial digital syndrome. Next is taurodontism, also called as bull's teeth, where the crown is expanded at the expense of the root. Okay, so there is increase in the size of the crown, results in decrease in the size of root. Okay, the total length of the tooth remains the same. So this increase in size in the crown leads to again abnormally large sized pulp chambers. So this is the fourth condition. The first one was dentinogenesis imperfecta type 2. Second was dentin dysplasia type 2. Third was regional odontodysplasia. Fourth is taurodontism characterized by abnormally large sized pulp chambers. Okay. Now again, how do we classify taurodontism? In this, we take the ratio of the crown body and root size. Okay, this is the crown. This is the crown body and this is the root size. If this ratio is less than 1.10, we'll take it as normal. If it is 1.10 to 1.29, then we'll call it as hypotaurodontism. If it is more than 1.29, that means from 1.3 to 2, then we will call it as mesotaurodontism. And if this ratio is greater than 2, then we will call it as hyper taurodontism. Okay, hypertaurodontism. Three types: hypo, meso, hyper. Based on the ratios, basically the extent is increasing. The expense at which the crown is getting enlarged at the expense of the root, that is increasing. Important syndromes associated with orthodontism are Klinefelter syndrome, amylogenesis imperfecta. We did this in Wittkopf's classification. Which type? Type 4 is the one which is associated with orthodontism. Down syndrome, ectodermal dysplasia, and trichodento-osseous syndrome. Now, this trichodento-osseous syndrome, these are characterized by, tricho word is for hair. So, kinky or coiled hair are present as shown in the picture. Dental features like taurodontism, other than taurodontism, enamel hypoplasia can also be seen. Okay. And osseous features, there is sclerosis of the bone. So sclerotic bone is seen in the skull. So important features of the trichodento-osseous syndrome are kinky hair, coiled hair, enamel hypoplasia, taurodontism, and the presence of sclerotic bone in the skull. Okay. Then is Pierre-Robin syndrome. This is an important triad of micrognathia. Now in this micrognathia, most commonly involved bone is mandible, cleft palate, and because of the micrognathia, there is glossoptosis. Okay, so it's an important triad of micrognathia, cleft palate, and glossoptosis. Pierre-Robin syndrome should not be confused with Perry-Romberg syndrome. Okay, similar sound, Perry-Romberg. Now this is associated with facial hemiatrophy. Half side of the face undergoes atrophic changes. Now previously it was thought that facial hemiatrophy is one of the manifestations of scleroderma, but now it has been proven that both these diseases are independent. But still, there was a question in the previous year NEET exam wherein the question was Pere-Romberg syndrome is associated with scleroderma. Okay. Other important findings seen in Pere-Romberg syndrome other than facial hemiatrophy is contralateral Jacksonian epilepsy. Okay. Contralateral Jacksonian, sorry, Jacksonian epilepsy. Jacksonian word is named after the scientist. It's a type of epilepsy, and more importantly, it is associated with trigeminal neuralgia. Trigeminal neuralgia. First is facial hemiatrophy. Second is contralateral Jacksonian. It is SO. Okay, I'll spell it here again. Jacksonian epilepsy. Okay, and trigeminal neuralgia. Next is an important sign seen in scleroderma or facial hemiatrophy is coupe de sabre. Coupe means scar. Sabre means rounded knife. Okay. So this is a scar seen in the middle of the forehead, as if the scar being created after a trauma with the rounded knife. This is seen. Coupe de sabre is associated with facial hemiatrophy or Pere-Romberg syndrome, and it is also seen in scleroderma. Next is, as shown in the picture, syndrome associated with cleft lip and lip pits. Yes, you must have guessed it by now. It is Van der Wood syndrome. Okay. Important points remembered from this is presence of cleft lip and presence of lip pits. That is Van der Wood syndrome. Next are the developmental anomalies of the tongue. The important one in this is geographic tongue, which is also called as benign migratory glossitis. As the name suggests, migratory means it is changing its position. So it is also called as erythema migrans. Okay. Now, different shapes of these erythematous lesions, they resemble the shape of the continent seen on the globe. Hence, the name is geographic tongue. And often these lesions, the areas of the erythema, they are surrounded by white lines. These are surrounded by white serpentinous lines. Okay. Serpentinous means like snakes, as shown in this picture. You could make out these white lines. These are white serpentinous lines. Now, geographic tongue has got the same histopathology as that of psoriasis. That means the histopathology of psoriasis and geographic tongue are same. Okay, and geographic tongue are same. And what are these common findings? That is presence of test tube shaped retirages. Test tube shaped retirages. The retirages, they appear like test tube shape. Okay. And second is presence of Monroe's abscesses. This is a coincidental histological similarity between psoriasis and geographic tongue. Both these diseases have different etiology. So geographic tongue is not a oral manifestation of psoriasis. These diseases are independent of each other, just that they have common histological findings as test tube shaped retirages and presence of Monroe's abscesses. Sorry, this is N. Okay, Monro, Monroe's abscesses. Okay, these are the collection of neutrophils seen in the epithelium. And clinically speaking, patients having geographic tongue also developed fissure tongue. So these two developmental anomalies of the tongues are usually seen together. Again, their etiology is different. This is just based on coincidence. Persons who are already having geographic tongue can also develop fissure tongue. Okay. Now next anomaly is median rhomboid glossitis. As the name suggests, it is present right in the center and it is rhomboid shaped. Basically, this is a developmental anomaly which is formed due to the non-fusion of tuberculum impar with lateral lingual swellings. If you remember the development of the tongue, anterior to third is formed by the fusion of lateral lingual swellings with tuberculum impar. So if this fusion does not take place, it leads to a rhomboid shaped defect which is devoid of filiform papillae. This area is devoid of filiform papillae. Okay. Now some group of researchers, rather the second most common etiology for this is they count this lesion as a candida associated lesion. Candida associated lesion. Okay, so but our first preference will be, if asked, first etiology is developmental, second most common etiology is candida. Okay, second most common etiology will be candida. They say that because of the presence of the candida, there is atrophy of filiform papillae. So it is a candida associated lesion. The presence of candida is causing atrophy of filiform papillae. Okay. Then whether it is developmental or it is candida associated, the rubbing of the soft palate with this tongue can cause inflammation of the soft palate, which is called as kissing lesion. Basically, this is inflammation of the soft palate and uvula. So such a type of lesion is called as kissing lesion. Kissing lesion is associated with median rhomboid glossitis. It is not to be confused with kissing disease, which is another name for infectious mononucleosis, right? Which is caused by Epstein-Barr virus. Next is macroglossia. Now, macroglossia, as the name suggests, large sized tongue is seen. Now, this increase in size could be either due to a primary developmental anomaly, or it could be secondary to some accumulation of any product, or secondary to some growth of neoplasm within the tongue. For example, hemangioma, lymphangioma, leiomyoma of the tongue can lead to large sized tongue. Okay. Now, clinically, such a tongue imposes a pressure upon the lingual surface of the teeth. Hence, impression of the lingual surface of the teeth are seen on the outer border of the tongue. So, the outer border of the tongue becomes scalloped. Such scalloping is called as crenated border. Okay. This is called as crenated border. The outer border, because it is exerting pressure against the lingual surface of the teeth, this type of border is called as crenated border. Next is hairy tongue. This is basically a desquamation disorder, wherein that results in the elongation of filiform papillae, and because these papillae are elongated, so there is accumulation of the food debris, so they take up different food pigments from the bacteria, different color can be seen. So simplest treatment is advise your patient to clean his tongue. It resolves within 2 to 3 days. Okay, just give him a tongue scraper and the lesion is completely resolved. Then is the lingual thyroid. This is nothing but ectopic thyroid tissue seen over the posterior part of the tongue. Basically, we know that in the tongue there is foramen cecum. From this foramen cecum, the thyroglossal duct starts, and this thyroglossal duct ultimately give rise to thyroid gland in the neck. And once the thyroid gland is formed, this duct goes off. Okay, if some remnants are left behind, these remnants can form thyroglossal duct cyst in the neck. So if the remnants are left over the tongue, they form ectopic thyroid tissue. In 70% of the cases, this is the only thyroid gland present. Okay. So problem comes when this thyroid gland is unable to meet the demand of the body. So functional hypothyroidism leads to increase in size. So clinically it presents as dysphagia, difficulty in swallowing, or dysphonia, difficulty in speech, and the most severe is dyspnea, that is difficulty in breathing. So such cases where this is the only thyroid gland should be treated medicinally. One should not excise them out and make the patient devoid of thyroid gland. No, treat such patients medicinally unless and until the surgery is mandatory. Okay, so this completes our developmental anomalies. Now we move on to the next topic, that is benign and malignant neoplasms. This topic is benign and malignant neoplasms of the oral cavity. First, we will discuss the benign neoplasms of epithelial origin. In this, the first is squamous papilloma. So, this is a benign neoplasm of epithelial origin. Main etiology involved here is this is stimulated by human papillomavirus type 6 and 11. As the name suggests, this papilloma exhibits finger-like projections and has a warty surface. Okay, warty means cauliflower-like surface. Cauliflower-like surface. Important syndrome associated with multiple squamous papillomas is Cowden syndrome. This is an important triad for multiple trichomomas. Basically, trichomomas are the hamartomas of the hair follicular tissue. These are the hamartomas of hair follicular tissue. As you could see in this picture, this is basically trichelomoma. Then multiple papules in the oral cavity and acral keratosis. Okay. Acral keratosis, multiple trichomomas and multiple papules forms an important triad for Cowden syndrome. The gene involved in Cowden syndrome is P10 gene, located on chromosome number 10. Okay, P10, just remember 10 is located on chromosome number 10. Okay. Next is keratocanthoma. Now, keratocanthoma is also known as pseudocarcinoma. It is also known as self-healing carcinoma. Types of HPV associated with keratocanthomas are many, namely type 9, 11, 13, 16, 18, 24. Okay, and the clinical hallmark for this keratocanthoma is this is seen in the surface of the skin which is facing sun, and there is a formation of craters filled with keratin. This forms the clinical hallmark for keratoacanthoma. Hallmark for keratoacanthoma. Now, this keratocanthoma, it mimics clinically as well as histopathologically with squamous cell carcinoma. But the best part is that keratocanthoma is self-limiting. It heals within few months, whereas squamous cell carcinoma is not self-limiting. The histopathological resemblance comes because of pseudocarcinomatous hyperplasia. Pseudocarcinomatous hyperplasia. Next is nevi. Nevi is nothing but excessive proliferation of nevus cells. Now, what are nevus cells? Nevus cells are nothing but a type of rounded melanocytes. Rounded melanocytes. Depending upon the location of these nevus cells, nevi have been classified into three types, depending upon their location, whether they are present in epithelium or connective tissue. The first type is the junctional type, wherein the cells are present along the basement membrane, right? The second type is the compound type, where the cells can be seen, nervous cells can be seen in both epithelium as well as connective tissue. And the third type is in the oral cavity, it is called as intramucosal type, in which the cells are seen only in the connective tissue. Okay, this is the third type. Now, the out of these junctional, compound, and intramucosal, the one which has got the worst prognosis is junctional nevi, because it exhibits Abdrubfunk phenomena. Now, Abdrubfunk phenomena means falling off from the roof. Falling off from the roof. Basically, the cells in the junctional nevi have got the potential to migrate into the connective tissue and become atypical. So they have got maximum potential to become malignant. This is seen with junctional nevi. Hence, the worst prognosis out of the three types of nevi is seen with junctional nevi because of Abdrubfunk phenomena. Now, there is a special type of nevi which is very commonly seen in the oral cavity is blue nevus. In the oral cavity, the most common site is palate. Often the question asked is the most common site is palate, and histopathologically, rather than rounded melanocytes, the shape of the melanocytes, nevus cells here is fusiform. Fusiform is like this shape, spindle shaped nevus cells are present. They are not rounded, they are fusiform shaped nevus cells. Now these fusiform shaped nevus cells, they exhibit Tyndall effect. That is why they appear bluish in color. Tyndallization, Tyndall effect. Okay, you must have read Tyndall effect in your physics. Tyndall effect is associated with light. That is why the color is appearing bluish. A special type of nevi which resembles the color of a wine is known as port wine nevi. This is seen associated with Sturge-Weber syndrome. Sturge, where do you see port wine nevi? The answer is Sturge-Weber syndrome. Now, this Sturge-Weber syndrome is also called as encephalo-trigeminal angiomatosis. Okay, as the name suggests, angiomatosis, basically this is dealing with blood vessels. So calcifications of the blood vessels in a skull radiograph have been compared with a parallel tramline track. Okay, so basically tramline calcifications are seen in Sturge-Weber syndromes. These tramline calcifications are seen in Sturge-Weber syndromes. Sturge-Weber syndrome. Next is benign connective tissue neoplasms. Important one in this is lymphangioma. Basically, lymphangioma is benign proliferation of, this is benign proliferation of lymphatic vessels. Angioma word is for vessel. So, benign proliferation of lymphatic vessels is called as lymphangioma. Such a lesion which causes massive diffuse swelling in the neck, diffuse swelling in the neck is called as cystic hygroma. Basically, cystic hygroma is nothing but a type of lymphangioma. Now, lymphangioma is very commonly seen in head and neck, and in head and neck, it is very commonly seen in tongue. Okay? Most common site in the oral cavity is tongue. Almost 80% of the cases in the oral cavity are found on the tongue. And over the tongue, lymphangioma appears clinically as gray to pink colored nodules. Gray to pink colored, small size nodules. These have been compared with, as shown in this picture, these have been compared with either frog's eggs appearance, or Tapoica pudding appearance. Tapoica pudding appearance. Okay, these nodules which are seen in lymphangioma, which are characteristically seen over the tongue, have been compared with the poica pudding or frog's egg appearance, right? Next is neurofibroma. Now, neurofibroma basically it's a benign proliferation of neural cells, that is Schwann cells, and connective tissue cells, that is perineural fibroblasts. Perineural fibroblasts. So both Schwann cells as well as perineural fibroblasts are proliferating, hence the name neurofibroma. Now this could be either solitary or it could be syndrome associated. The most common syndrome associated with multiple neurofibromas is neurofibromatosis, also called as von Recklinghausen disease of skin. Okay. Now, in this, two types of neurofibromatosis. Neurofibromatosis type 1 is because of the mutation in the gene called as neurofibromin gene. Neurofibromin gene, which is located on chromosome number 17. Whereas neurofibromatosis type 2 is because of the mutation in the gene known as Merlin gene, which is located on chromosome number 22. Many important clinical signs are often asked from neurofibromatosis. These are, first is, as shown in the picture, you could make out multiple neurofibromas are seen. Sometimes many neurofibromas fuse together to form a pendulous mass that gives bag of worms appearance. Many neurofibromas fuse together. Okay, now this forms a bag of worms appearance. Sometimes large sized pendulous masses are formed and they have been compared with elephant face. So elephant man syndrome is the name given for neurofibromatosis. These are the real pictures taken from the person suffering from neurofibromatosis. Then is, as we have also discussed this in bone pathology, these are cafe low pigmentations or cafe-low macules, which have got smooth border as compared to polyostotic fibrous dysplasia, where the borders are irregular. Here the borders are smooth. Hence, they have been compared with the coastline of California. And brown color freckles seen in axillary region. Such freckles are known as crow's sign. Okay, crow's sign is nothing but the presence of freckles seen in axillary region, whereas scaphomacules can be seen over the skin. These are outlined with regular borders, smooth borders, and have been compared with the coastline of California. Other important clinical signs are Lish nodules. Now, Lish nodules, basically these are melanocytic melanocytic hamartomas seen in iris. Melanocytic hamartomas seen in iris part of the eye. Whereas other important sign is gliomas. Gliomas is nothing but the neoplasms of glial cells. Optical gliomas, which are seen in optic nerve. So these are called as gliomas. Next is neurilemoma or schwannoma. One M is missing here. Neurilemoma or schwannoma. Basically, this is benign proliferation of Schwann cells. These Schwann cells, they are arranged in two type of cellular arrangements called as Antony type A cellular arrangement or Antony type B arrangement. This is basically not a type of cell, rather a type of cellular arrangement. Antony type A arrangement, the Schwann cells are arranged in parallel rows and their nuclei shows palisaded appearance. Okay, they have got palisaded nuclei. Palisaded means the nuclei of the adjacent cells are at the same level. So they are arranged in parallel rows with nuclei at same level. And the centermost part is devoid of any nucleus, is called as Virchow body. We'll show diagram on the next slide as well. This is known as Virchow body. On the contrary, Antony type B is nothing but a random arrangement. The cells are arranged randomly. Okay, they are randomly arranged. So in type A, these Schwann cells, as shown in this diagram, they are showing palisaded appearance of the nuclei, palisaded appearance, as well as this part which is devoid of any nucleus. This is called as Virchow body. Virchow body. Okay. Basically, this is hyaline, homogeneous, eosinophilic, okay, acellular, anuclear, no nucleus, no cell in this area. This is the actual picture. This is called as Virchow bodies. And type B arrangement. In this arrangement, the cells are arranged randomly. Okay. Next is osteoid osteoma and osteoblastoma. These are again the benign neoplasms of bone. As the name suggests, osteoid osteoma basically is lesser than 2 centimeters in size, and it is more commonly seen in calvaria as well as jaw bones. Okay. Whereas osteoblastoma is usually more than 2 centimeters in size, and the most common site is axial skeleton. Now, the important question asked often is the night pain is relieved. Sorry, these osteoid osteomas have got receptors that respond to aspirin. So, night pain is relieved with aspirin in osteoid osteomas and not relieved in osteoblastomas. Okay, because osteoblastomas do not contain any receptors for aspirin. Whereas, so both these lesions are painful. Night pain is seen in both these conditions, but it is relieved with aspirin in case of osteoid osteoma, whereas it is not relieved in case of osteoblastoma. Next is malignant neoplasms. This we will be doing in basis on the basis of the special appearances. For example, the very first appearance is where do you get to see herringbone appearance or herringbone pattern. This herringbone pattern is seen in fibrosarcoma. Fibrosarcoma, as the name suggests, which cells are proliferating here? Atypical fibroblasts. Now these atypical fibroblasts, they are arranged in small streaming vesicles, okay, like small rivers. So these streaming vesicles, they are arranged in herringbone pattern. Next is where do you see storiform pattern? Storiform pattern is seen in fibrous histiocytoma. Now this fibrous histiocytoma, as the name suggests, fibroblasts are also proliferating and histiocytes are also proliferating, and it is basically very aggressive, such that many researchers believe that this it is not a benign neoplasm, rather it should be counted as a malignant neoplasm because of its aggressiveness. Okay. Question to be remembered is storiform pattern is seen in fibrous histiocytoma. Next is where do you see staghorn pattern? Staghorn pattern is seen in hemangiopericytoma. Now, what is this hemangiopericytoma? As the name suggests, hemangio means blood vessel, peri means surrounding. So, which cells are proliferating? The cells which are surrounding the blood vessels. They are proliferating. What will happen when the cells surrounding the blood vessels are proliferating? So, the blood vessels will be compressed. So, these compressed blood vessels give an appearance of staghorn. So staghorn pattern is seen in hemangiopericytoma, right? Next is, where do you see onion skin appearance radiographically, layer by layer addition of the bone? This is mainly seen in Ewing sarcoma. Okay, important lesions from this chapter is osteosarcoma. Can also be seen in Gares osteomyelitis and many other conditions, but we will be discussing these two here with respect to this chapter. First is Ewing sarcoma. Now, Ewing sarcoma basically is a round cell neoplasm commonly seen in children affecting the long bones. Very common. And these cells have got cytoplasm which contains glycogen. Glycogen rich. Cytoplasm is rich in glycogen. Hence, they take up per iodic acid Schiff stain. Pass positive cytoplasm, which is rich in glycogen. And these cells are arranged in filigree pattern. These cells are arranged in filigree pattern. Okay. Next is osteosarcoma. Now, osteosarcoma is the most common primary malignancy of the bone seen in children as well as young adults. Whereas for adults, this is the second most common malignancy, which is the most common malignancy, most common primary malignancy of bones in adults or elders is multiple myeloma followed by osteosarcoma. Okay, multiple myeloma. Sorry, the E will come here. I spelled it wrong. Now, osteosarcoma, as we know that it's a malignant neoplasm wherein atypical osteoblasts are proliferating. Atypical osteoblasts are proliferating. Since these, what is the function of osteoblasts? They form bone, osteoid, whereas atypical osteoblasts will form tumor osteoid. This is not normal. This is called as tumor osteoid. That means bone is being formed, but these trabeculae are randomly and haphazardly arranged. Hence, this random and haphazard arrangement is also compared with cumulus cloud appearance. Okay, cumulus cloud appearance or sunburst appearance. Sunburst appearance is also seen in osteosarcoma, right? Next is, where do we see starry sky appearance? Starry sky appearance is seen in Burkitt's lymphoma. Now, Burkitt's lymphoma is basically a B cell neoplasm. Two types, sporadic type that is seen elsewhere in the world and endemic type which is mainly seen in Africa. Now, this African type is characterized by jaw swelling and enlargement of cervical lymph nodes. Hence, it is also called as African jaw lymphoma. Okay, whereas sporadic type is characterized by formation of abdominal masses. Another important clinical sign is presence of ascites. Okay. Next is, where do you see owl's eye or mirror image appearance? Owl's eye or mirror image appearance of nuclei is seen in Reed-Sternberg cell. Reed-Sternberg cell. Now, these Reed-Sternberg cells can be seen either in Hodgkin's lymphoma or they can also be seen in, second preference will be cytomegalovirus infection of salivary glands. Cytomegalovirus infection of salivary glands. Another important type of cells which can be seen in Hodgkin's lymphoma are popcorn cells and mummified cells. Basically, these cells represent atrophic changes in the nucleus. Atrophic changes in the nucleus. So Reed-Sternberg cells, popcorn cells, and mummified cells can be seen in Hodgkin's lymphoma. Next is, where do you see cigar-shaped nuclei? Cigar-shaped nuclei is seen in leiomyosarcoma. As the name suggests, leiomyosarcoma. This is the malignant neoplasm of smooth muscle origin. Okay, smooth muscle origin. Next is potentially malignant disorders. Well, this term was given by WHO in the year 2005. This is basically a terminology that includes both pre-malignant lesion as well as pre-malignant conditions. Before 2005, we used to enlist, this is pre-malignant lesions and pre-malignant conditions. Before 2005, we used to enlist three pre-malignant lesions, namely leukoplakia, erythroplakia, and third one was palatal keratosis associated with reverse smoking. A special type of practice which is usually seen in southern parts of India, Andhra Pradesh. Okay, mostly women, what do? They put the lit end of the BD or cigarette inside for smoking. So that causes palatal keratosis. This is included as one of the pre-malignant lesion. Whereas the 7 pre-malignant conditions are oral submucous fibrosis, lichen planus, two types of lichen planus, namely atrophic. Not all the variants are pre-malignant, only the two variants, atrophic variant as well as the erosive variant of lichen planus. Syphilis mainly in the tertiary stage, because in the tertiary stage it causes atrophic glossitis or interstitial glossitis. So basically this atrophic glossitis or interstitial glossitis leads to squamous cell carcinoma of tongue. Or white lesions seen in discoid lupus erythematosus, sideropanic dysphagia, epidermolysis bullosa, and xeroderma pigmentosum. These are the 7 pre-malignant conditions. But now these terms are obsolete. Pre-malignant conditions and pre-malignant lesions are clubbed together as potentially malignant disorders. Okay. Next is leukoplakia. Now leukoplakia means any white lesion in the oral cavity. Basically, it presents either in the form of a white patch or white plaque, which is non-scrapable and which cannot be characterized clinically as well as histopathologically as any other white lesion. Basically, leukoplakia is the diagnosis by exclusion. Once we rule out all other known white lesions and we do not come at the final diagnosis, we give the clinical diagnosis as leukoplakia. So leukoplakia is purely a clinical term. Histopathologically, leukoplakia will appear since it is a white lesion, so it shows hyperkeratosis, excessive formation of keratin, hyperkeratosis, with or without dysplasia. Dysplasia may or may not be there, but hyperkeratosis will always be there. If dysplasia is there, then we have to tell the grade of dysplasia, whether it is mild, moderate, or severe. So, how do we grade dysplasia? We divide the epithelium into three parts. If the dysplastic features are seen only in the lower if the dysplastic features are seen in lower one-third of epithelium, then we call that type of dysplasia as mild dysplasia. If the dysplastic features extend from the basement membrane till the two-third part of the epithelium, then we will call this as moderate dysplasia. And if the dysplastic features cover the entire epithelium, the entire thickness, then we will call it as severe epithelial dysplasia, or called as carcinoma in situ. Carcinoma in situ. Okay. Now, what are we seeing in this epithelium? We are seeing the dysplastic features, namely increased nucleocytoplasmic ratio, cellular pleomorphism, nuclear pleomorphism, increased mitotic figures, drop-shaped retirages. Okay. If these features are confined to the lower one-third, then mild dysplasia. If it is confined to the lower two-third, moderate. If it covers the entire epithelium, it is severe or carcinoma in situ. Okay. So if patient has got leukoplakia, then histopathologically it will be hyperkeratosis with or without dysplasia. Okay. Now, if dysplasia is present, then we will tell whether it is mild, moderate, or severe, depending upon the extent of the involvement of epithelium. Okay. Next is oral submucous fibrosis. Now, oral submucous fibrosis, basically it is characterized by either there is increased production of collagen or there is decreased destruction. Ultimately, either the production is more or the destruction is less. Net result is fibrosis. Okay. Now, the chief etiological factor involved in OSMF is areca nut. Now, this is in contrast to tobacco, which is the chief etiology for leukoplakia. Okay, this is something different. In OSMF, chief etiology is areca nut. Why areca nut? Because this contains high amounts of copper, and copper acts as a coenzyme for cofactor for the enzyme lysyl oxidase. This lysyl oxidase helps in stabilizing the collagen. Okay. Okay, let me repeat. Areca nut, areca nut, that is your supari, contains copper. This copper acts as a cofactor for the enzyme lysyl oxidase. This lysyl oxidase forms cross-linking of collagen so that collagen becomes more stable. Hence, the more stable it is, what will happen? Less destruction. Less destruction means more and more accumulation. More and more accumulation. Okay. Now, histopathologically, OSMF is divided into two stages. One is early lesions. In the early stage, there will be, because this disease starts as a response to inflammation. Okay, so there will be vasodilatation of the blood vessels, vasodilation of blood vessels, vasodilation of blood vessels, and there will be epithelium will show hyperplastic changes. So epithelium will be hyperplastic, whereas in advanced stage or advanced lesions, because of more and more of fibrosis, now the blood vessels are getting compressed. So compressed blood vessels will be seen. Okay, blood vessels will be compressed in advanced stages. Now the vascularity is decreased, so the epithelium will show atrophic changes, and hence atrophic epithelium will be seen in advanced stages. Okay, hyperplastic epithelium is seen in early cases, whereas atrophic epithelium is seen in advanced cases. Okay. Then is verrucous carcinoma. Now, verrucous carcinoma is basically warty variant of squamous cell carcinoma. Now, this warty variant of squamous cell carcinoma is also called as Ackermann's tumor. Ackermann's tumor, and it is also called as snuff diapers lesion. Snuff diaper lesion. Now, this is the only carcinoma present where there is no break in the basement membrane. The basement membrane is intact. basement membrane is intact. So it does not metastasize. There is no invasion. There is no invasion. The hallmark for malignancy, invasion, is missing. It does not metastasize. Okay, that is why it is considered as a special variant of squamous cell carcinoma. Clinically, the surface shows finger-like projections, hence it is called as warty variant. Now, the since the basement membrane is intact and still we are calling it as carcinoma, why? Because it causes destruction similar to the carcinoma. Localized destruction is seen. Localized destruction similar to carcinoma, similar to CA. Why this localized destruction is seen? Because of the presence of broad elephant foot rete ridges. Broad elephant foot rete ridges causes destruction similar to carcinoma. Hence, it is called as carcinoma. And how will you treat this? Simply, you need not go for radical neck dissection. Treatment is simple surgical excision. This has got very good prognosis. Okay. In contrast to conventional squamous cell carcinoma, where modified or radical neck dissection has to be carried out, here simple excision and prognosis is very good. Okay. So this completes our benign and malignant neoplasms.